Hi, Dr. Brian Kaufman from ASH 2012, family doctor with CLL, doctor turned patient.
I'm Adrian Wiestner, hematologist and investigator at the National Heart, Lung and Blood Institute in Bethesda, Maryland.
Dr. Wiestner, you've been presenting some exciting data about Ibrutininib, and could you talk a little bit about this medication and how you see it fitting in, where it's going in the treatment of CLL?
I think the fantastic news with kinase inhibitors in general, and Ibrutininib as one of them, is that they really induce responses across the spectrum of CLL patients. So we see a great benefit in patients who've been previously untreated. There were cohorts for elderly patients. And we see equally good responses actually in patients who've had multiple regimens before, who have adverse cytogenetic markers, who are classically in groups you would not who do not so well with standard treatment approaches.
So this would apply to patients with unfavorable prognostics like unmutated 17p, F refractory. Is that what you're talking about here?
Yes, that's our hands-on experience in our own trial, where the data is not as mature yet as in the phase 1/2 trial, where an update will be presented this afternoon. But if it's our own experience, and if we look at the data in the phase 1/2 trial, patients continue to benefit even if they have 17p deletion or have been refractory to their previous treatment.
Do we understand why it's working when standard chemoimmunotherapy approaches have been wanting for those that high-risk group?
I think it's really reflecting that this is a completely new concept, how we attack CLL cells, how we inhibit CLL cell growth and survival. The B-cell receptor inhibitors turn off one of the key survival signals of these cells, whereas many of our previous treatments, at least, relied on inducing DNA damage, and p53 mutations or p53 deletion, the 17p deletion, will make these cells resistant to the DNA damage response. So we are coming truly with a whole new concept, and so one could expect that these drugs will work, and it's rewarding to see that they do work in patients who are otherwise refractory to chemotherapy.
And the adverse event profile, in your experience, has been good?
So it's another remarkable feature of the clinical trial we run is with Ibrutininib, so I can only hands-on speak about side effect profile on Ibrutininib. And it's really extremely well tolerated in the majority of patients. So some patients really don't feel like they're getting treatment, and that's a quote from one of our patients. Some patients initially have some degree of fatigue, some degree of diarrhea. The longer treatment goes, that usually settles down. Or patients develop their strategies, so they know, for instance, to avoid certain foods. And you know, in many elderly patients, the loosening is actually not terribly uncomfortable, right?
One of the other features of this that I've seen in some of the data is the durability of the responses. Has that been your experience too?
Our trial's been open for 10 months, so in our own experience, we've had 3 patients progress early on. All 3 of them have had a transformed disease, so CLL plus Richter's transformation into large cell lymphoma or into Hodgkin's disease. But patients with CLL, everybody that started is still on drug, is still benefiting. We have not seen progression events in this short period of time for true CLL patients.
That's incredibly exciting, because these were high-risk patients that you were looking at, just high-risk patients.
We are looking at, we have patients who are relapsed refractory high risk in that sense, and we have a cohort for patients with 17p deletion, which at least by this cytogenetic markers are the high risk patients, yes.
So where do you see these, where are they in their development? Where do you see them fitting into clinical practice?
So at this point, or in the new year, we will have several trials set up that aim towards registration of kinase inhibitors. So GS1101 and Ibrutininib will enter these type of studies. I think really everybody who's using these drugs is impressed by what they do clinically and how the patients benefit. So I think these trials will accrue very quickly, and approval is certainly not certain at this stage. The trial has to be completed. But if anything we've seen in the first phases of the clinical development hold up, then I think approval will soon follow.
All right. And where do you see them being used? I know this is kind of premature, but you see them being restricted to the high-risk patient? Do you see them as front line? Where do you see them in the elderly?
They are active across the spectrum of CLL. So I think potentially they will become a treatment option for everybody. What we don't know is what, if there is any, what is the long-term toxicity of such drugs? Are there any downside of being on this for several years? Will they be used as single agents to kind of chronically keep CLL in check? Or will we incorporate them into combination regimens, trying to achieve a cure, trying to achieve really deep, long-lasting remissions? So a lot of that will depend on this. And some decisions that are really hard to make at this point. Should a younger high-risk patient go to transplant or try such a kinase inhibitor first and see how far it can go? Probably over time, this may become a patient choice, you know, that depending on your own approach to solving a problem, do you go full out for the maximum you can achieve, or do you try with a more low-intensity approach to keep things in check?
I think you're talking to me when you're saying that, because that's kind of one of the decisions that I look at, you know, being a patient on Ibrutininib and looking at the issue of a transplant down the line. And it sort of parallels the whole circumstance with Imatinib and how it developed.
Right, it does, yeah.
What's your thoughts on the combination? And I know that one of the things that appeals as a patient is avoiding chemotherapy. So it's less appealing to me when I look at a trial that mixes it with an alkylating agent, and more appealing if it's with another biological or what. So I'm just throwing that out. But what's your approach as the researcher?
So I'm excited by the potential of using chemotherapy-free, so non-chemotherapy-based treatments to induce deep remissions in CLL. I think that is the area I would like to put my efforts into. That said, we don't even know really if you need something, you need to add something to it. Imatinib is used as a single agent. There are important differences between CLL and CML. I don't mean to just say this is the same case. But as an example, there we use single agent. And I think we don't know yet how far single agent in this case can take us. But so my efforts would go towards non-chemotherapy based treatments. However, there is a good rationale to use these drugs in combination with chemotherapy. We know chemotherapy works. CLL is, at least up front, very sensitive to chemotherapy. And adding such a kinase inhibitor could do two important things. One is get these cells out of lymph node and bone marrow where they can be resistant to chemotherapy. And it can block some of the survival pathways. So you could actually really have a magic combination. And I'm sure colleagues will also address this, will investigate this.
There's an issue with the treatment of having a low amount of residual disease that remains but doesn't seem to take off. Does that concern you at all?
again, I think we're somewhat early. If you look at what is the slope in response to these drugs, in the first 2 months there's a lot happening. Cells are coming out into the blood, lymph nodes shrink. We're also seeing that in some cases the bone marrow empties out pretty quickly, so the tumor goes out of the marrow pretty quickly. Then things seem to slow down, and progress is somewhat slower from the 2 to the 6 month period. And maybe progress is slowing down further from 6 to 12 months. But as long as you continue to make progress, I think I would see how far it takes us.
Great. We're going to just pause for 1 minute here, and then we'll finish things up.